Now, we're going to talk now a little bit more about the treatment, obviously, and we're going to start by just kind of the approach of SGAs is this old model of treatment using medications for developmental disabilities that I think is best described as a shotgun approach. It tends to use fairly high potency agents that are tranquilizing, sedating, slowing, for generally externalizing high-frequency behaviors, aggression, destructive behavior, and hyperactivity. It tends to be historically something that is driven by a problem behavior and is seen as a solution to the problem behavior. It also tends to involve, historically in research, the most impaired individuals. Most of the research, when you look historically at trials of medication and studies, are the ones who have failed medication trials, are very, very seriously impaired. At the same time, when you look at the studies, they really don't pay attention or describe the developmental profile. So they say a child with autism without really describing the rest of the development. And as you know today, as you've seen today, the rest of the development profile is key. And as a result, no surprise, it hasn't been a particularly successful approach until the SGAs came out, the second-generation antipsychotics. Now, I got more interested in this a couple of years ago when my colleague, Dean Elby, who's a pharmacist at BC Children's Hospital, wrote a paper which summarized the use of SGAs in autism spectrum disorder, and wrote a very nice study where he looked at all the data and found that there were, at that point, 10 randomized controlled trials, RCTs, which is the highest level of evidence you can get with this type of study with SGAs, and concluded, based on analysis of those 10 studies, that basically there's pretty good data that SGAs are relatively safe. They provide meaningful improvements in behavior with good large effect size, meaning that not only do they improve behaviors, but they improve them substantially in these studies. But all the evidence is short to medium term, or immediate to short term. And virtually no evidence in this paper, in the research, for the type of use that SGAs are generally used for, which is chronic. Now, when you look at prescription trends with SGAs over the last few decades, it's also kind of concerning. So SGAs in autism spectrum disorders have, the prescription for them have really escalated in the last 2 decades. Between 1993 and 2002, 5 to 6-fold increase, to the point that now SGAs occupy about 90% of all antipsychotic medication prescriptions. The other antipsychotic medications are the first generation, FGAs, we would call them. We don't call them that. But first-generation antipsychotics like haloperidol, chlorpromazine, and so forth. And so now 90% of antipsychotic prescriptions are SGAs. We also know, even predating the information on SGAs, that there is an issue with long-term health implications for individuals with developmental disabilities. Individuals with autism are much more prone to being obese. They're much more prone to having hyperlipidemia, independent of anything else. This reduces not only the quality of life, it reduces the length of their life.
What is it?
Too much cholesterol, high cholesterol. So they have high cholesterol, blood sugars, metabolic sort of things. The sort of things that create heart disease, strokes, and so forth in long-term life. And in addition to that, just as a baseline risk factor, having an autism spectrum disorder, meaning that you have a higher risk of becoming obese and a higher risk of having these metabolic derangements, once you add an SGA into the mix, there's huge literature on how much fuel that adds to that fire and how much further it takes us. So we know now that predictably in children and youth, SGAs almost predictably lead to hypercholesteremia. Almost predictably lead to weight gain, which is why I kept saying the weight gain. And frequently also lead to associated hypercholesteremia, blood sugar problems in terms of diabetes, and so forth. And as a result, we have now developed another clinic. We have a metabolic mental health clinic at BC Children's Hospital. So we keep our children on these SGAs, but we give them another doctor. More appointments, more blood tests. You should see the list of blood tests we have to do. And we further medicalize these people's lives, right? The other concern I have is that the way us doctors work is we have habits too. And we tend to get into certain ruts. And one of the things that has happened is that with the popularity and the popularization of SGAs in the community right now, it's starting to crowd out other possibilities. So this is an example of one of the ones that is of great concern to me. Anxiety disorders, as I have already said today, are very common in kids with autism spectrum disorders. Up to 40% of them have it. We also know that anxiety disorders in kids respond really, really, really well to SSRI antidepressant medications. It's probably the best response for an anxiety disorder is to an SSRI antidepressant medication. I don't know how many of you remember the black box warning with SSRIs that came out about 10, 15 years ago. And what had happened was that there was a meta-analysis that someone did, which was a big study kind of looking at previous studies on SSRIs, and concluded in this that kids on SSRIs were at higher risk of having suicidal-related events, which could be suicidal thoughts, suicidal acts, not completed suicides. And this led to a whole level of concern, appropriately so, about the use of SSRIs in kids. And the United States led to what was called a black box warning, which is basically the highest level of warning you can put on any medication use, and basically tells the prescribing physician, be awfully careful, someone might sue you. And in the United States, this is a real thing. And so what happened, as soon as this black box warning arrived, is SSRI prescriptions for youth fell. Not a huge surprise that would happen. There was a really interesting study that Olson did, where he actually looked at kids and looked at the prescription patterns and found that as the prescription rate for SSRIs was declining in these years, guess what was climbing? SGAs. We weren't not treating these kids with medication, we were just treating them with the wrong one. And so now Olson looked at it and said that for a primary diagnosis of an SGA, this is an American study, an SGA being used for an anxiety disorder, which has no evidence of its effectiveness in an anxiety disorder, more than doubled. So I couldn't leave this alone. And so I, with Dean's cooperation, and he actually he's the editor of this section of the journal, so he can do this, invited me to write a rebuttal. And so I did write this rebuttal, and this kind of summarizes the basic problems with the research, and I think this remains true in large part to today. This was about 2 years ago that I put this together. So basically, all the quality studies that we have on SGA's use in kids with autism are 12 weeks or less. Now, that's not unusual in large part for a lot of psychopharmacological studies because they're expensive to do. The longer you carry them on, the harder they are to do. However, you have to keep in mind that all the studies we have only go to the 12-week mark. There are a few studies that go up to 6 months, but those are mostly involving adults. Now, in my experience, I have yet to see a child who's only on an SGA for 12 weeks. It's 12 weeks, usually what happens is either they get started by the pediatrician or the GP or in the emergency room, and then there's an appointment made for a psychiatrist 12 weeks later, or 14 weeks later, or 16 weeks later. And at that point, things are a little bit better, and who's going to take the medication away? Right? And so 6 months later, the kid's still on it. The typical pattern of use of these medications, if you do nothing else, is that a kid gets put on them and they stay on them for long lengths of time. So the research we have, I think we have to be honest, does not apply to the way we use it. If you use it only for 12 weeks and you say, we are going to stop it at 12 weeks, maybe. Although I'm not sure that would be anything we would do. The other is, what have the studies actually measured in terms of improvement? When I say there's large effect size in terms of improvement, what do they measure? Well, it's actually, when you drill down, it's actually kind of curious. It measures in most of these studies, a very particular aberration on a very specific subscale of a psychological tool. On the ABC, the irritability subscale of the aberrant behavioral checklist, which is used as a marker for irritability. Now this is, again, you've heard me talk about terms and words and how we create things. Irritability has become a construct based on the ABCI, as if it is a real thing, as if the ABCI irritability is a real thing, and that in and of itself, a reduction in the ABCI score, is a good thing. Right? It was created as a measure of irritability that we wanted to reduce with certain medications, but it becomes a life unto itself. The other is that even then, sometimes that's one way of measuring improvement is the ABCI. Other studies measured in a lot of different ways. For example, there's a couple of these studies that actually use the CARS, which is a quote-unquote diagnostic tool. Now, we know medications don't improve or change core symptoms of autism, so how do you get a change in the CARS score, which is interesting in and of itself? I think there was nothing here. Right. Case definition. As I was saying earlier, most of the cases, when you look at this, there's real problems with knowing if the kids that are being described in these studies are like the kids that I have in my office. One is they rarely do they define how the kid was diagnosed. So they say they're autism, but based on what? Based on what kind of autism? And the more I do this work, the more I know autism here is different than autism in Toronto, how it gets defined in autism in Toronto, how it might get defined in Victoria and in Calgary. And that's just within one country or even one province, for that matter. And unless we know that the kids being described there are like the kids in my office, applying the research is going to be very problematic. In general, the studies really underestimate the impact of intelligence and IQ, which I've really tried to emphasize for you today. Some included intellectual disability in the mix. Some said they excluded severe or profound intellectual disability. But it was very unclear. Now, the FDA has made some changes to its requirements now for any new trials going forward on new agents that are specifically for autism. The FDA now does require the ADI and the ADOS as a standardized tool to define the phenotype. But this is relatively new, and really there's any agents out there yet that have utilized this. We kind of touched on this as well, is that the subjects that we are talking about in these studies are the most severe and most treatment resistant. Almost all of them have substantial externalizing behaviors, which is why they're participating in a research study. They have low baseline functioning, and very, very, very often they've had multiple other trials of medication that they've been unresponsive or partially responsive to. So they're already a complicated population. Now, again, if that's who you are treating, that's fine. But most of the kids that I see aren't like that, right? The level of severity, even when you look at the ABCI scores on the kind of pre and post, are so elevated. These are almost kids who are in crisis. Now, we all know our kids will sometimes have crises, but most of these kids don't live their life in crisis. They live their lives between these crises, perhaps. And so using that temporary model for how these kids are as a global model, they're always going to be irritable, they're always going to be in crisis, and therefore we need always treat them like this, is problematic. Now, this is really interesting. Most research studies, independent, whether autism or anything else, really like to have very pure samples. They like to have pure ADHD or pure depression or pure anxiety or whatever, because that way there's less confounders, and if you're introducing a treatment, you can actually measure whether it's going to be effective without having all these problems. Now, and so as a result, many studies will actually say we exclude anybody who has a psychiatric comorbidity. So one possibility with that is that we are now looking at research studies like the RUPPA and we are now looking at research studies that actually don't apply to the majority of kids with autism, because as I've been telling you all day today, most of these kids have psychiatric comorbidity, so we're only talking about 20% of the kids, so then why do I care? I mean, you know me, my point here. Or what we're saying is that they all had psychiatric comorbidities, but they weren't identified. Right? So then this mix gets all even more confusing. Finally, really a lack of guidance that has been provided to physicians on how to start, when to stop these medications. I think one of my biggest bees in my bonnet are the residents in the emergency room at Children's Hospital. who start our kids on SGAs because there's nothing better that they can do. And us doctors, when you see a doctor, we like to do something. And if we have a prescription pad, we'll use it. It's the reality. It's the reality of anything. You go to your mechanic, they're going to try and fix something. You go to the doctor, it's what we do. You go see a doctor, you're likely to get a prescription. And in the emergency room, it's not infrequent. People will say, well, okay, I'm not sure what else to do here. You know, they've got a team, but let's put them on a little bit of risperidone. And now what I tell the residents is every time you write that, the first prescription, you've taken 5 years from this kid's life. Because that's what you're doing. You're changing the course of their metabolic changes, and you're causing increasing health illness, health burden for these kids. Okay. That was the rest of my rant. Now we're going to go into my happy space.